No? Ano to, nagtuturo ng ano? Tubig? Start na tayo. Pero 88 pala. Hahapon pa kaya yung iba? Anyway, mag-start na lang tayo. Magdasal muna tayo. In the name of Father, the Son, the Holy Spirit. Amen. Say, we thank you, Father God, for all the blessings that you have showered to us. Thank you for this wonderful day. And we continue to pray for your protection against this virus. Protect us, protect our family and friends. And today, once again, we are going to learn something about cerebral blood flow. We hope and pray that this will help us and guide us and become better physicians. This we ask and pray in Jesus' name, our Lord. Amen. Handa na ba kayo? Ano lang yung lecture natin today, short. Maybe, hopefully, we will be finished in about 30 minutes. So this is about cerebral blood flow, cerebrospinal fluid, and the brain metabolism. Okay, just a quick review of the cerebral blood flow. Now, you will discuss this in neuroanatomy or also in anatomy. And you know that the blood circulation to the brain is made up from the circle of Willis. You have 4 major vessels contributing to that circle of Willis. You have the 2 internal carotid arteries and the 2 vertebral arteries. I'd like to point out yung anatomy, the middle cerebral artery is a direct branch of the internal carotid artery. And that's why if there is an emboli, anatomically, it would go through the middle cerebral artery. And the middle cerebral artery supplies the lateral portion of the cortex. And that's why if there is thrombosis or an emboli in this artery, it would cause infarction of the cortex supplied by the middle cerebral artery. It would result into contralateral loss of sensation and motor function. Whereas yung artery, the anterior cerebral artery supplies the middle portion of the cerebral cortex, which if you review the homunculus, that's where the lower extremities is located. And so if there is an embolism or a thrombosis in this artery, it would result to contralateral loss of motor and contralateral loss of motor and sensation. Okay? Ano pa ba? Some important features, for example, if the left middle cerebral artery is affected, and it would affect the patient more as compared if it's the right middle cerebral artery, because diba yung Broca's area at saka yung Wernicke's area is on the left hemisphere, and so if the left is affected, then it would cause loss, parang the patient will be demented. Okay, I hope mako-correlate niyo yon. But of course, if the patient is yung Wernicke's area or the dominant hemisphere is on the right, then iba naman yung presentation niya. Okay, so the 2 vertebral arteries unite to become the basilar artery. In the book, it says that the posterior cerebral artery is coming from the internal, it's a branch of the internal carotid artery. Pero parang looking at it, no? Parang siyang direct branch from the basilar artery. Pero the book says it's a branch of the internal carotid artery, so let's believe on it. The 2 communicating arteries, the anterior and posterior, makes up the completes the circle of Willis. So this circle of Willis is coming from the basal portion of the brain, meaning sa ilalim, and then it will spread towards the center and the lateral and the superior portion of the brain. Okay? Ay ko na mga turo-turo. All right. So once these are big middle-sized arteries, it will branch out into smaller arteries, and yun yung PL artery, which will penetrate the pia mater and becomes or branches off into smaller arteries that are the penetrating arterioles and arterioles. So there is that space, yung Virchow-Robin space, that's a subarachnoid space, and it separates this penetrating artery from the brain tissue. So this penetrating arteriole, hindi siya, it does not combine with the brain tissue immediately. There are structures that separate this penetrating arteriole to the brain tissue. So there are foot processes there, and that there are before, once these capillaries penetrate the pia mater, then there are foot processes and pericyte and gap junctions. That's where the transport of oxygen, carbon dioxide, and other metabolites would occur. All right. So meron kayong nakikita ditong picture, yung excitatory neuron, yung glutamate. So itong cell na to, this is actually astrocyte. Para siyang, if I have to remember it, I correlate it with janitor fish. Para silang mga trabahador lang. But they are so many in the brain tissue, and they somehow help the neurons to grow. They give nutrients to the neurons. At the same time, one of its function is to provide these foot processes that makes up this tight junction. Para there is no direct, it creates this blood-brain barrier between the capillaries and the brain tissue. So the normal rate is 50 to 65 milliliters per 100 grams of brain tissue per minute, and the entire brain would receive 750 to 900 ml per minute. Alam niyo na yun, when we were discussing cardiovascular physiology, you know that the brain tissue receives a great amount of the cardiac output, and that's because the brain tissue does not provide or does not produce its own glucose, and that's why it needs constant blood supply for glucose. Okay, the blood flow to the brain tissue is regulated by several factors, and this includes carbon dioxide concentration, hydrogen ion concentration, oxygen concentration, and the last are substances released from astrocytes. You need to memorize all these four because it will come out in the exam. Either an increase or a decrease of these substances would result to an either increase in flow or a decrease in flow to the blood circulation. Let's talk first about the carbon dioxide concentration and hydrogen ion concentration. So if there is an increased amount of carbon dioxide, it will combine with water and you form bicarbonate and also hydrogen ions. And this hydrogen ion has a direct effect in causing vasodilation of cerebral vessels. So any form of hyperacidity, like lactic acid or pyruvic acid, it would increase H+, and so causes vasodilation, not just carbon dioxide, but yung pinaka-important substance is carbon dioxide. It indirectly causes vasodilation or increased blood flow, whereas hydrogen ion directly causes an increased blood flow in the brain tissue. So if you look at this graph, on the y-axis is the cerebral blood flow, and on the x-axis is the arterial PCO2. So the arterial PCO2, the normal value is between 35 to 45, and the mean is 40. So for example, if you look at the graph, if there is a rise in the arterial PCO2 more than 45, it also directly increases the cerebral blood flow up to 1.2 to 2 times the normal limit. And on the opposite side, if there is a decline in the arterial PCO2, there is also a direct proportional decrease in cerebral blood flow. So take note of that. And there is a reason for that. And that's because an increase in carbon dioxide, as I said, increases the hydrogen ion, and this hydrogen ion will decrease the neuronal activity. An increase in hydrogen ion concentration increases the blood flow, but this is something physiologic, and you want to remove kasi this hydrogen ion, you want to remove the carbon dioxide and other acid-forming substances in order to protect the brain tissue so that you can maintain neuronal activity. Okay, so it helps maintain a constant, the increase in blood flow as an effect to hydrogen helps maintain a constant hydrogen ion concentration in the cerebral fluids and thereby helps to maintain a normal constant level of neuronal activity. Okay, so increase in carbon dioxide, increase in hydrogen ion, increase in blood flow. Next up is oxygen deficiency. So if there is a decline in oxygen, there is also an increase in blood flow, opposite to carbon dioxide. So the rate of utilization of oxygen is 3.5 ml per gram per minute, and a decrease in oxygen would result into a vasodilatation, returning the brain blood flow and transport of oxygen to cerebral tissues to near normal. So something physiologic. We need the brain tissue, the neuronal cells have no capability for anaerobic activity. Kaya it needs constant supply of oxygen. Okay, so review: increase in carbon dioxide, increase in hydrogen ion, increases blood flow. A decrease in oxygen increases blood flow. The last is substances released from astrocytes. So yung astrocyte is a type of glial cell. Sobrang dami ng astrocytes in the brain tissue. They help, they are glutaminergic neurons, and that's because it uses glutamine as a neurotransmitter. And the net effect is an increase in calcium. And this increase in calcium would result into vasodilation. Okay, so apat yon, an increase in carbon dioxide, increase in hydrogen ion, as well as an increase of substances released from the astrocytes would result into vasodilation. Opposite to oxygen, if there is a decline in oxygen supply, it would result to vasodilation. So alam niyo na, sa exam, ang exemption is oxygen. So there are other mediators, let's say nitric oxide, metabolites of arachidonic acid, potassium ion, and adenosine. All of these substances would result to vasodilation. Okay. Autoregulation. The blood flow to the brain is autoregulated, which means that it will, all the mechanisms will be produced in order to maintain the pressure inside the brain, and that's between 60 to 140 millimeters mercury. Even if there is a rise of mean arterial pressure up to 160 to 180, the pressure in the brain would still be maintained at 60 to 140, and this is to prevent stroke. Diba? So, for example, the sympathetic nervous system, which comes from the superior cervical sympathetic ganglia, which we lectured last time, there are sympathetic ganglia coming from, let's say, the T1, it will go into the superior cervical sympathetic ganglia and joins together with the arteries supplying the brain and with the penetrating arterioles. So there are sympathetic nervous system there, and it would, an acute rise of mean arterial pressure, it will stimulate this sympathetic nervous system to vasoconstrict the vessels, the large and intermediate sized arteries, and the purpose is to decrease flow of blood into the cerebral cortex. And this is something physiologic because you don't want to increase the flow of blood and increase the pressure as well in the brain. Otherwise, these vessels, the arterioles and capillaries supplying the cortex would rupture and would result into cerebral hemorrhage, okay? A cerebral stroke, a form of cerebral stroke, which is cerebral hemorrhage. And that's why there is an important role of the sympathetic nervous system in controlling the blood flow and the pressure in the brain, okay? Hi. So you see this picture, there's the gray matter and there's the white matter. Now there is a concept in physiology that if the tissue has more function or has more metabolic activity, then the blood supply to that tissue is more, there are more capillaries supplying that tissue. So if we compare the gray matter versus the white matter, there is more function in the gray matter, and that's why there are more capillaries, 4 times greater in the gray matter as compared to the white matter. Okay, the brain capillaries are less leaky. It means to say that it prevents this communication of, somehow there is that blood-brain barrier between the capillaries and the brain tissue, and somehow it's to protect you from, it's to protect the brain tissue from the infection, so that the microbiota will not enter to the brain tissue easily. So this is opposite to some organs, let's say in the liver or in the kidney, wherein the brain capillaries are more leaky. So small arterioles become greatly thickened in hypertensives because of remodeling. If there is an increase in blood pressure, the endothelium will be more thickened, and so the lumen will be reduced. And this is the reason why eventually some patients will have cerebral infarction. So yun, because in constant blood pressure, increase in blood pressure would result into concentric remodeling of the vessels, and it would thicken the lumen, and I mean the endothelium will be thickened, decreasing the lumen, decreasing the blood flow. Okay. So there are 2 types of stroke, the hemorrhagic and that one that is caused by atherosclerosis. So pag hemorrhagic, the most common cause there is aneurysm. Alam niyo na, if there is aneurysm, that's commonly congenital and increase in blood pressure, or eventually if the wall of the arteries ruptures, it would cause into hemorrhage. Whereas atherosclerosis takes time to build up, 5 to 10 years in the making. The atherosclerosis would start in the endothelium and pushing the atheroma will build up in the intima, and pushing the lumen towards pushing the endothelium towards the lumen, decreasing the lumen size, decreasing the blood flow. So yun yung mechanism to cause ischemia. So an increase in blood pressure, parang ayaw ko talaga yung term na burst, no? Kasi, although ganun din naman yung burst, kasi sa layman's terms, sumasabog daw. Para tuloy nilang naiisip na granada siya na sumasabog. But yes, if there is rupture to the blood vessel, then the blood will seep out into the brain, into the brain tissue, and since the skull is stiff, so if there is buildup of blood in the subarachnoid space, for example, it would push the brain tissue and it would further compromise its function. Okay, I have explained this already. If there is obstruction of the middle cerebral artery, it would produce a more, if it's on the left side, for example, where the Wernicke's area is there, it would produce a greater damage as compared to if the right middle cerebral artery is obstructed. And that's because if there is infarction to the Wernicke's area, which is the center of intelligence and the ability to speak, okay, not speak, but ability to understand language. So at the same time, kasi if it's the middle cerebral artery, there will also be infarction to the Broca's area, so the patient will be aphasic. Kaya para siyang bobo na or demented yung patient. So thrombosis to the left middle cerebral artery would have a greater impact as compared to thrombosis to the right middle cerebral artery. Okay. Let's now go to cerebrospinal fluid system. Okay. And I don't know if you have mnemonic, but you need to memorize this CSF flow from where it's produced up to where it is to be absorbed. So yung mnemonic ko up to now is, come let me treat Sally for lunch mamaya sa aristocrat. I don't know if it will help you or you have your own mnemonic, pero that's my mnemonic. So come let me treat Sally for lunch mamaya sa aristocrat. C, so it's produced from the choroid plexus. And the CSF will now go to the lateral ventricles. And then you have the foramen of Monroe. And then next to that is come let me treat. That's a third ventricle. And then treat Sally. So the CSF fluid will now enter into the aqueduct of Sylvius. Come let me treat Sally 4. So the foramen of Magendie, fourth ventricle muna. And then after the fourth ventricle, then you have for lunch. No, lunch is foramen of Luchka, and then mamaya is foramen of Magendie, and then finally into the subarachnoid villi. So if there is a problem in the production, meaning in the arachnoid villi, in the choroid plexus, or obstruction along the pathway of the cerebrospinal fluid, it would cause hydrocephalus. At the same time, even if there is just an enough production of CSF fluid, but the reabsorption is affected, for example, there is inflammatory process or fibrosis to the arachnoid villi, then it would result into a decreased reabsorption of CSF fluid, and again, build up of or increase in CSF fluid and pressure, it would still cause hydrocephalus. So ganun lang yung pathophysiology nun. So the cerebral cavity is about 1,600 to 1,700 ml, but the CSF fluid is 150 ml only. Okay, its function is to provide cushion in the brain tissue within its solid vault. So the brain and CSF have about the same specific gravity, so para lang lumulutang yung skull. But the problem is, for example, if there is concussion, so if mild lang na concussion, then the CSF will somehow protect the frontal lobe. However, if the acceleration is strong, then there will be injury to the frontal lobe. That's what we call as the co-injury. And then since there's a fluid, so the brain tissue will bounce back. And if that force is strong, the occipital lobe will also be injured. And this is what we call as the counter-co-injury. Okay? Yes. So nakikita din natin to we see this in vehicular accidents, but also in shaken baby syndrome. If you shake the baby, so it would cause a co and counter co-injury. So some patients, some baby will be comatose. All right. So how is it produced? And it's slow on its absorption. We produce about 500 ml of CSF fluid each day. It originates in the choroid plexus. So sinabi ko na, 2 lateral ventricles. And then memorize nyo na lang yung flow. Di ko alam if I made a question about the flow, but kailangan nyo pa rin i-memorize. So I think this is more lumalabas siya in neuroanatomy more than in physiology. Okay. So yun. All right. So how it's produced, you need to memorize this kasi physiology tayo, the concentration of electrolytes in the CSF fluid. So an increase in the quantity of osmotically active NaCl in the CSF would cause an immediate osmosis of water through the membrane, and this will provide providing fluid of secretion. So meron tayong characteristic, the sodium ion concentration in the CSF is equal to plasma, whereas the chloride ion, in terms of chloride ion, there are more chloride ion in the CSF as compared to plasma. And in terms of potassium, there's lesser amount of potassium in the CSF as compared to plasma. And then in terms of glucose, there are less glucose in the CSF as compared to plasma. So sinamarize ko na sa inyo. So don't be confused about that. Kailangan nyo siyang ma-memorize. So in terms of sodium ion and plasma, equal sila. In terms of chloride ion, there are more chloride ion in the CSF. In terms of potassium ion, there are less potassium in the CSF. And in terms of glucose, there is less glucose in the CSF, more glucose in plasma. Okay? So kailangan nyo siyang i-memorize. Okay. So the pressure of CSF is regulated. This is between 65 to 195 with a mean of 130 millimeters water or 10 millimeters mercury. So anything higher than 195 means increased pressure. Yeah. But there are a lot of regulations to maintain this pressure of the CSF fluid. So, for example, if this arachnoid villi would have inflammation, and if there is inflammation to this arachnoid villi or arachnoid granulation, it would result into prevention of absorption of the CSF, and it would result into an increase in CSF volume as well as an increase in pressure. So there's a valve action. This arachnoid villi and arachnoid granulation also acts as a valve, and it allows CSF to begin to flow into the blood when CSF pressure is about 1.5 millimeters mercury or greater than the pressure of the blood in the venous sinuses. So, for example, para lang siyang if there is an increase in pressure, it would allow parang more flow of CSF fluid. But if there is a decrease naman, it would close. So it acts like a valve. But its main function, the arachnoid villi, is to reabsorb the CSF fluid. So ayun, if there is a blockage to this villi, it would result to CSF, an increase in volume of the CSF, as well as an increase in pressure. Okay. So if there is a brain tumor, it would elevate the CSF pressure, and that's because you are blocking the reabsorption of the CSF. The arachnoid villi kasi will be blocked because of this brain tumor. So if the brain tumor is at the center, then if it's away from the flow of the CSF fluid, then somehow it will not affect. But if somehow it affects this tumor is increasing in size and it blocks somewhere along the way of the flow of the CSF, then the CSF volume will increase and the pressure itself will also increase. And decreasing reabsorption of the CSF back into the blood, yung ibig sabihin nun, if this tumor is obstructing the arachnoid villi, it would decrease the reabsorption of CSF and at the same time can also elevate the CSF volume and pressure. And it can rise as much as 500 millimeters of water or 37 millimeters mercury, which is about 4 times normal. Okay, so in hemorrhage or in infection, it can also increase the CSF fluid, CSF pressure. So sa infection naman, ang mangyayari is there is inflammation to the arachnoid villi, and so there will be a problem with the reabsorption of the CSF fluid. In hemorrhage, ganun din siya, large number of RBC or white blood cells can block the arachnoid villi. So the reabsorption is also affected. So it would also result to an increase in CSF volume and pressure. Okay, so in either if the arachnoid villi is obstructed by red blood cells or because of inflammatory process or fibrosis, the CSF would elevate up to 400 to 600 millimeters water, or which is also about 4 times from the normal level. Okay, in babies, there can also be an increase in CSF pressure, and it is often caused by abnormally high resistance to fluid reabsorption through the arachnoid villi, resulting either from too few arachnoid villi or from villi with abnormal absorptive properties, meaning they are born with abnormality in the absorptive property of the arachnoid villi, and that's why there is accumulation of CSF fluid and therefore an increase in pressure. So this is how we measure it. Parang basahin nyo na lang, no? Hindi nyo pa naman to level, but it's in your book kasi. So the patient is in the lateral decubitus position, and then you try to flex the legs kasi you want to open up the spinal column. So we insert the spinal needle in between the L4, L5, and then then we measure the pressure. In the tube, no? So the last time I performed this, sobrang tagal na, Diyos ko Lord. Residency training pa in second year. So parang, I don't know if you will have a chance to do this. If you go to neurology, I think you will be more experienced in doing this. But if you go into other subspecialty, then you will not be adept in performing this. This time, bihira lang kami mag-perform except if the patient has a CNS infection. That's the only time we do it. Or if we cannot really diagnose what's the cause of increase in CSF pressure. So for example, if we need to, aside kasi from measuring the CSF pressure, we can also send a specimen in the lab for culture or just to see if there are tumor cells. So there are also other benefit in doing this modality. Okay. So yung papilledema, the dura mater kasi, it extends up to the optic nerve. Okay. And then, so if there is an increase in pressure, it would push the optic disc. The optic disc is more pliable as compared to retina, So any increase in CSF pressure would push this dura mater and would cause edema through the optic nerve. And you can see this clinically, but to be honest, hindi din ako magaling I've been trying to see yung papilledema, pero hindi ko rin siya ma-appreciate. Yung mga ophthalmologists, sila yung magagaling nito. Para kasi siyang, you will use an ophthalmoscope and then parang I'm trying to learn how to perform this, pero ang hirap-hirap siyang ma-identify. But that's the picture that you need to look at if there is edema to the optic disc. Okay. Sure. So during residency training and also during internship, when we try to do checking the optic disc, pero hindi ko siya bet gawin. I don't know, kung mag-opta kayo, trabaho na yan. So there are two types of hydrocephalus. It can either be caused by an obstructive or non-obstructive, the obstructive or the non-communicating, or the non-obstructing or communicating. Okay. So pag obstructive, it means to say that there is normal production of CSF from the choroid plexus, but the problem is somewhere along the way of the CSF, there is blockage, and that's why CSF build up in the ventricles, and it would increase, the volume will increase as well as the pressure will increase. So in children, the most common cause is blockage in the aqueduct of Sylvius. Yun. Or it can be from a blockage of a brain tumor, or it can also be because of they are born with atresia of the aqueduct of Sylvius. So that's the most common obstruction in children, blockage in the aqueduct of Sylvius. Either they have congenital atresia of the aqueduct of Sylvius or because of a brain tumor. Okay. Pag non-obstructive naman, ibig sabihin, the flow of the CSF is okay, it's not affected. Also, the production of the CSF is also normal. But the problem is now in the reabsorption of the CSF. So it's on the arachnoid villi, and there can be some, so for example, in infection or inflammation or fibrosis of the arachnoid villi, then the CSF will not be reabsorbed and the CSF volume will increase as well as the pressure will increase. Okay. So I've been talking about blood-brain barrier, and this barrier exists both at the choroid plexus and at the tissue capillaries, but there are some exemptions. and this is in the hypothalamus, pineal gland, and area postrema. You have to memorize these three. Kasi pag alam niya, pag three, kahit anong kasing gawin mo, pag, for example, if you make a question, parang mag-accept ka lang, no? And then pwede mo na siyang pang-exam. So you have to think as a teacher, and then iisipin mo, ano ba talaga yung lalabas sa exam? So, para makakasagot kayo. So, ayan. So there is always exemption to the rule, and these are the three. That's because these three organs need constant or increased blood flow. Kasi they have sensory receptors that would respond to specific changes in body fluids. So alam niyo na yung hypothalamus, a lot of let's say a change in carbon dioxide would affect the breathing pattern. That's why it needs constant. The receptors has to be specific, has to receive blood for its function. Okay. There are highly permeable, slightly permeable, and almost totally impermeable substances. Kailangan niyo siyang i-memorize kasi lalabas din sila sa exam. So when we talk about highly permeable, this includes water, carbon dioxide, oxygen, and most lipid-soluble substances such as alcohol and anesthetics. Kaya alam niyo na pag mag-inuman kayo, no, parang agad-agad lang pwede kayong magkaroon ng disturbances in neuronal function kasi alcohol is highly permeable. Ganun din yung anesthetics, kaya yung patient tulog agad. Slightly permeable are electrolytes such as sodium, chloride, and potassium, and almost totally impermeable. Actually, kahit saan naman parang impermeable yung proteins because these are large molecules, and most of the non-lipid soluble large organic molecules. Okay? Yes. So the tight junctions allows this low permeability. Alam niyo, yung mga foot process ng astrocytes, it creates these tight junctions, and this is the one that creates this blood-brain barrier. So the membranes of adjacent endothelial cells are tightly fused rather than having a large slit port between them, as in the case for most other capillaries in the body, such as, for example, in the liver. Okay. So one of the most serious complications of abnormal cerebral fluid dynamics is brain edema. So kung magkakaroon ka ng brain edema, it would greatly affect the consciousness of the patient. Accumulation of the extra edema fluid compresses the blood vessels, often causing seriously decreased blood flow and destruction of brain tissue, usually caused either by greatly increased capillary pressure or damage to the capillary wall. So if there is brain edema, there's just a vicious cycle, and the mechanism can either be either of the following. So brain edema is commonly caused if there is brain concussion. So yung vicious cycle, for example, if there's it can either be from compression of the vasculature. So kung mag-edema ka kasi, since the circle of Willis is coming from the base of the skull, and then it goes superiorly before it penetrates into the center of the brain. So nasa labas sila. So if there is brain edema, it could compress these arteries or arterioles. So from the compression of vasculature, it will decrease blood flow and causes brain ischemia. And the ischemia, if there is ischemia, if there is a compression, a decrease in blood flow, it causes arteriolar dilatation, and a decrease in, if you compress the arteries, it would decrease the blood flow, it would decrease oxygen, and decrease in oxygen would cause arteriolar dilatation, which is still further increase capillary pressure. So don't be confused that at the site of brain edema, you compress the vessels. You compress the vessels, so it would decrease oxygen supply. So a decrease in oxygen supply will cause the other vessels, not compressed by the edema, it will cause the other vessels to have an increase in blood flow. And so there will be dilatation of these other vessels, and increase in blood flow, would cause more edema fluid, so the edema becomes progressively worse. The other mechanism is a decrease in cerebral blood flow also decreases oxygen delivery at the site, and it increases the permeability of the capillaries, allowing still more fluid leakage, and turns off the sodium pumps of the neuronal tissue cells, allowing these cells to swell in addition. So this is the vicious cycle of brain edema. Kaya for example, if there is vehicular accident, there will be concussion, and then we expect that there is brain edema. We have to do something to stop this vicious cycle, either from the compression of the cerebral arteries, which causes ischemia to the brain tissue, or from the vasodilatory effect of other vessels that causes an increased flow and then further increasing brain edema. Because if you don't counteract this brain edema, the patient will have more loss of consciousness. So the preventive measures from total destruction of the brain is either you have to give osmotic diuretics such as mannitol, which pulls fluid by osmosis from the brain tissue and breaks up the vicious cycle. Or you can do ventricular needle puncture, which remove fluid quickly from lateral ventricles of the brain. So clinically, what we do is we give the mannitol. We can easily give mannitol just to counteract this brain edema. Okay, the metabolic rate, simply lang naman. You just need to increase the blood flow because the brain tissue does not have the ability to produce its own glucose. And that's why you need a constant blood supply to the brain. Under resting but awake conditions, the metabolism of the brain accounts for about 15% of the total metabolism in the body. The neurons, or most of the excess metabolism of the brain, and pumps ions through their membranes. So it pumps sodium and calcium out while it pumps potassium in. Okay, brain is not capable of anaerobic metabolism as compared to the heart. So if there is less oxygen, then the neural activity will be affected. Okay, sinabi ko na to, glucose is the food for the brain, and the brain has no capability to produce its own glucose, and that's why you need constant blood flow. In diabetic patients, yung entry of glucose into the brain, it does not need insulin, unlike in other tissues. It needs insulin for the glucose to enter. So a patient is diabetic, hindi affected yung brain kahit walang insulin because glucose can still penetrate the brain tissue. The problem in diabetic patients is if you give too much medications to lower the blood glucose. So if the patient has hypoglycemia, okay, then yun ang magiging problem because the patient will have coma, brain coma. Ay, andyan pala. So yun, if you overtreat the patient with insulin, glucose can fall extremely low because insulin will deliver glucose to insulin-sensitive non-neuronal cells throughout the body. So it will affect hypoglycemia will affect the brain more than hyperglycemia. And so hypoglycemia, kaya patients who are hypoglycemic, if too severe, can result into coma or mental imbalances or psychotic disturbances. But this is easily treated. You just have to check the CBG. If it's so low, you just give glucose and then akalain ng patients na akalain ng family na the patient is na stroke na, but if once you give glucose, bigla silang will be back to normal. It's para siyang miracle. Okay? Yay! Natapos na. Short lang siya na lecture. I hope may naintindihan kayo. I am now opening the floor for some questions. 10:47. So, natapos tayo in 45 minutes. Yay! So, natapos na natin lahat ng lectures. Again, yung chapters na hindi ko na-discuss, hindi yun lalabas sa exam. Hindi ko alam kung ilang items yung sa exam ko, but I think you will have a quiz this Wednesday. So, puro lang sa akin yun. So, kung long quiz, 50 items yun. Lord have mercy, 50 items. So, galingan nyo. Kailangan pumasa kayo lahat. But during the bi-monthly, hindi ko pa alam kung ilang items yung sa akin. Okay? Questions? Wala na? So wish me luck. Magva-vaccination tayo. Ay, wait. May nag-question. Hello, Doc. What are the signs and symptoms of brain concussion? So, for example, if I have patients referred to me, most of the time, this brain concussion hindi sa akin na-admit, but referred only to me because I am an internist. So, if there is brain concussion, kung gaano ka-severe yung concussion, ganun din yung manifestation ng patient. So, most of the time, yung concussion, the effect to that is kung saang area ng cortex yung affected. For example, kung frontal lobe, or temporal lobe, or occipital lobe. So, depende lang yun. But most of the time, patient with concussion would result into loss of consciousness and motor ability. So, para din siyang stroke. So, no matter kung severe yung concussion, then all extremities will be affected. There will be motor loss and sensor. Sensya na si Kuya naglinis. Ngayon pa naman si Kuya naglinis kung kailan nagle-lecture ako, no? So, ayan. So, yung manifestation is para lang stroke. Kung anong area yung affected, ganun din yung manifestation. So, there will be motor loss, there will be sensory loss. But in brain concussion kasi, the main effect is because of brain edema, increasing the CSF flow, then halos global yung pag-increase yung CSF, pag-increase yung intracranial pressure kasi hindi na siya para lang stroke na a single area of the cortex is affected and the other area are normal. A CSF, an increase in intracranial pressure, it will affect the entire brain. So the sensorium will be affected. So the patient will either be comatose or obtunded. So we use Glasgow Coma Scale to measure the level of wakefulness of the patient. Alam niyo na yun. So GCS3 is more severe as compared to GCS15. Did I answer your question? Meron din namang cerebral concussion na minor lang, so it would produce probably like headache, mga ganun lang, or kung yung brain edema is not so significant, kaya headache lang yung magiging effect. Also, some patients will have nausea, will have vomiting. So these are signs of increased intracranial pressure. So yung pupils are dilated, then there will be loss of motor function and sensory loss in all extremities. Ganon yung mga manifestations nila. Moya-moya. I have one patient lang. Nagkaroon lang ako ng experience with one moya-moya. So in moya-moya, if I remember right, their arteries are so small. Sobrang liliit nila. So we have to read more about this moya-moya kasi nagkaroon lang ako ng experience ng moya-moya. So in moya-moya, small yung artery. So para siya magpresent as stroke, pwede din kasi myocardial infarction because their arteries are so small. So when the arteries are constricted or small, then it would result to a decreased blood supply to the brain. So they would appear as if they have stroke. Okay. Regarding treatment, I'm sorry, I'm not very good with moya-moya. Nakalimutan ko kung anong treatment niya. We have to read about it. Can aneurysm be prevented? Okay, there is a way to prevent that. For example, I have one patient actually who died last night because of aneurysm. She was diagnosed at 4 years old with a saccular aneurysm of the brain. I forgot which artery. She was advised to have surgery. So what they do is they put a coil. Alam mo yun, lalagyan lang ng coil yung aneurysm para hindi na siya mag-rupture. Okay, yun lang yung gagawin. Or, they can try to clamp the proximal and distal and then try to fix the aneurysm. Ganun. So, that's how to prevent that. They must have surgery. Otherwise, kung hindi sila magpa-surgery ahead of time, kung mag-rupture na yun, wala. Talagang sobrang taas ng mortality because there's nothing we can do. Hindi mo naman siya maoperahan agad-agad kasi kung operahan mo siya, they become comatose kasi once mag-rupture yan, tuloy-tuloy lang yung blood, yung hemorrhage. And then since the skull is stiff, alam niyo yung it would compress the brain tissue and the patient will be comatose and the patient will die. Kaya sobrang taas ng mortality if there is a hemorrhagic aneurysm. So they would present, yung mga manifestations lang is of course dizziness, headache, pero pag mag-rupture na yan, they would present with severe sudden onset of severe headache, ganun ang percentage. Hindi siya gradually increasing. Talagang at onset, severe, and then pak, kumatos agad. That's most likely manifestation of subarachnoid hemorrhage coming from aneurysm. Yes, dizziness can be a manifestation, headache can be a manifestation, but these are just non-specific manifestations. Ano bang pinag-uusapan natin? Yung sa concussion pa rin ba? Pag hindi pa kasi mataas yung intracranial pressure, it would present as dizziness, headache, nausea, vomiting. Pero pag severe na, coma agad ang mga manifestation, ganun. Did I answer the question? So Isabel Granada bang pinag-uusapan natin? So if you have aneurysm, then you need to do surgery ahead of time, before pa siya mag-rupture. Kasi po once mag-rupture na yan, wala, goodbye Philippines. Questions? So na-interest kayo sa aneurysm. Yung best friend ko died from aneurysm when I was second year medicine. Kaya after that, nagpa-CT scan talaga ako. Pero plain lang. Dapat kasi ano yan eh. Dapat kasi CT scan with contrast or MRI. Brain MRI. Mas maganda. So kung meron kang mga headache, you start with plain CT scan and then we do kung talagang we are highly thinking of aneurysm, then we do CT scan with contrast or MRI. That's how we diagnose aneurysm. Question? Wala na. Going once? Going twice? Thank you very much. Good morning, everyone. Mag-aral kayo.
Thank you po, Doc.